Dr. Stephen Murphy is a genomic medicine pioneer. He's a 10-time top doctor. His research helped change medical policy in this country, and his work has been covered everywhere from the Wall Street Journal to Bloomberg. He teaches the molecular basis of disease to the doctors who will one day treat your children. He wrote the book on GLP-1 medications, and he practices the kind of medicine that looks at the whole man, not the 15-minute slot.
DocPod presents Health with Dr. Hal.
Steve, welcome to the show.
Oh, Hal. Listen, Dr. Hal, thank you so much for having me. It's an honor to honestly be on your show. This is awesome.
Are you kidding? You're one of my mentors from the day I met you. And honestly, it was through the group chat, right? It was the longevity group chat where we were just kind of shooting the shit in there. And I realized I'm talking to another me who's willing to be super serious when it's absolutely necessary, but never takes himself seriously either.
That's the key. When you got to bring it, bring it. The rest of the time, life is too short.
Absolutely. It's like the great Van Wilder said, right? You can't take life too seriously. You'll never get out alive.
You never will get out alive, but
ideally
we do it the right way.
You're trying to keep people from, or at least get as long as they can out of it. But there's a line that I saw on your website. We are made to be well. I want you to unpack that for the guy who's been told his whole life that being tired at 40 is just what 40 feels like.
Well, it's simple. We are made to be well. Our body has all the systems we need to heal. The problem is that we don't treat the body right. We burn the candle at both ends. You and I both know this. High performers always sacrifice things. And in our world as doctors, 80-hour work weeks are for the weaklings, right? So being a high performer, functioning at your best level, it wears on you. I don't care how resilient you are. And so we are made to be well means we're made to be well. If you are not well, you are not giving your body what it needs to heal and be well. And that's the important point here, especially in men, right? Men, women too, but in this case, men are always expected to shut up and push through, right? That's the problem, I think, in my mind.
No, you're absolutely right. Precision medicine, what you do every day, it got its nice name from two presidents, but most men still get that one size fits all care. What does standard insurance-driven medicine actually miss when it treats the range instead of the man in front of it?
Whoa, this goes way back. And I'll tell you, Dr. Hell, seriously, I've been helping men with hormone optimization, lifestyle optimization, athletic optimization for 2 decades. And what I've seen is nothing short of criminal. We have insurance companies not willing to pay for some testing, which now has been exposed through companies like Function Health, only costs $10 or $12, right? So the insurance is only going to pay for that once a year. And you know as well as I do, lots of things in your life change those hormones. And if you're on supplementation or you're taking some strategy to boost your levels of testosterone or other beneficial hormones, you have to track them. And insurance often won't cover them. That's number one. Number two, insurance is not going to pay for you to spend an hour talking with your doctor about how you can optimize your lifestyle to boost your energy level, to give your body what it needs to be well. I don't know about you, but when I was taking insurance for years, literally, I would have an office filled with patients. I ran myself 5 exam rooms plus a waiting room, and we were always double or triple booked. So because of that, what was I doing? I was trying to do the best care I could, which included, in room 1, go get an EKG. In room 3, well, I want you to do a post-void residual for them for their BPH. In room 2, go get PFTs and go draw blood in room 4 while I'm in room 5, right? So you just can't give great care when you're like a short order chef. That's literally like you and I are both brilliant dudes. Slinging bacon and corned beef hash as fast as we can it's not what we should be doing, but that's what insurance values us at. That's a big problem for patients.
That's actually the perfect way to describe it. It's turned into, short order, short, what is it? Short
You short
order.
order cook, right? You're
Yeah,
like,
your
hey, I
short
got to
order
turn
cook.
this over. I got to get bacon and eggs, and then I got to get a ribeye steak, and you're like at the diner, like slopping up slop for patients when you are literally like, especially you, Dr. Hal, you're like a I'll give you a couple. You're like a 2 or 3 star Michelin star chef, and so it's true. So if insurance isn't going to pay for the Michelin chef because they want a can of cat food served to the patient, you can't rely on that insurance to get a beautiful bone-in cowboy ribeye. You just can't.
It's unfortunate that they've convinced doctors, or they've convinced patients that doctors are, the responsible party here, when we're just trying to do our best. I mean, we went into medicine to take care of people, not to see 25 patients in a day and spend 7 minutes with them and then spend, 30 minutes charting. It's untenable, the situation right now in traditional medicine. So I love seeing pioneers like yourself who have made a wild success of yourself practicing precision medicine, so that you've led the way for, the rookies like us to
Yeah,
come
yeah.
along and try to do it a little bit more at scale, which is what I'm trying to do at Game Day. And it really, standard insurance driven medicine is, you're treating, you might treat that one lab and that's it, and we don't treat the lab, we treat the guy in front of us. We treat the man holding the lab.
And
I
that
wanted
I'll
to.
tell you, that's what I like about your team at Game Day. Being able to deliver, you can call it precision, you can call it personalized, but what I like is patient-centered care for men's health. You are putting the patient at that center. You are not slapping combo number 5 on the patient, going like, "Hey, I found this peptide stack on the internet. Here you go, Wolverine." Right? Like you are actually doing the right thing at Game Day. And that's something you should be very proud of.
It's with help of my mentors like yourself. Honestly, I take a lot back when we have those meetings with longevity docs and in those group chats. And then your Substack has been incredible. I don't know why you don't have 1 million followers on that Substack. It's just a wealth of information. There's sometimes, I'm on that FDA committee, where I go back to your Substack and I find more information there than I do from, some of the other information sources that are out there for us. So thank you for what you're doing, by the way, because you're
It's a
truly leading
pleasure.
the way on that.
It really
Um,
is a pleasure. Thank you.
I know you enjoy it, and that's the only way you can do it day and night, if you actually enjoy it. You wrote the book on GLP-1 medications, and I've seen you have very polite discussions online with certain doctors about how obesity medicine wasn't a thing until it was a thing, and now it's a well-respected field, and how now longevity medicine is sort of going through that same evolution. But GLP-1 medications, every guy has heard of them now, right? What's the one thing that the internet has just gotten flat out wrong about GLP-1s?
Oh, it depends on where you go and what rabbit hole down the internet, right? And it's very the internet and the internets, the interwebs and the social media, they love polarization and outrage, right? So either it's the next best thing in the world and it cures herpes, right? And right, or HIV too, right? These are incurable diseases, and GLP-1s cure them, right? I say that as a point for hyperbole of how awesome it is. The other side is GLP-1s will make you go blind, you'll lose all your muscles, and you'll lose your girlfriend to some big guy on testosterone, right? So, like, these are the crazy realms for men with the GLP-1. I think what people are missing in a GLP-1 is the following, and I'm going to say this not as an FDA representative or anything like that, because if I was, I couldn't say this. These medications are very powerful. They act on multiple systems in your body, and we don't know exactly everything that they do. As a general rule, the lowest dose possible is what you should be on. I don't see that with my good gym bros. I don't see that in the massage parlor or your buddy's bodega that you sent me a picture of selling peptides like tirzepatide or Retta, right? These medications need to be tailored differently for different people. And this goes to precision medicine. You're not going to see that anywhere else on the internet. A subset of people will never respond well to the GLP-1s. You're not going to see that on the internet. You're going to see these kill you or these make you live forever, because that's where it's at. It's wrong. Some people, they're excellent meds. Some, they're not. And in fact, some who have adverse effects often probably have too high a dose for them. And so the strategy of bringing your dose down as low as possible will lead to ultimate success for what? Well, simple. Reduce inflammation, reduce adiposity, optimize metabolism, and optimize your energy, your ability to be well.
That metabolism piece, that's something that I harp on a regular basis with patients who look at GLP-1s and have turned them into their personality. GLP-1s are not a plan. They're a tool. They're going to help with your, the initial weight loss, but really by fixing your hormones, getting your metabolism right, making sure that you're eating, making sure you're in the gym with the gym bros and putting on muscle, keeping muscle while you're on these GLP-1s. That's how you do it right. So a GLP-1 is a tool, not a personality. You got to fix the hormones, use the tool, keep the muscle, in that order. That's how I look at it. Hormones and testosterone, they go hand in hand. GLP-1s and testosterone for me, they go hand in hand. Testosterone is currently, I think, the most politicized molecule in men's health today. Every guy has an opinion on it. Most of them, I think, are, they get out a little bit into the, like you said, into the polarizing space. What do you wish most guys knew about testosterone before they even touch it?
When you play with your hormones, you better be prepared. There are always consequences with everything that we do in life, right? You won't get a life insurance policy if you like skydive or ride motorcycles, right? Or it's going to be through the roof. Everything comes with a risk. Utilizing hormone optimization through direct hormone replacement always comes with a risk. You need to have great guidance, great laboratory monitoring, and great lifestyle to maximize the benefits of TRT. I had a guy, oh my God, billionaire, like legit, like the guys that you live near, literally, seriously. And he comes to me and he
Not the
says,
same
I've got
neighborhood,
more
by the
money
way,
than,
that I live
yep,
near. Not the same neighborhood.
yeah, fair. His boat is just around the corner from your house. So I literally, right, seriously, he came to me, he says, I have more money than God. Your job is to keep me alive forever. Oh, and I've got this TRT doc in like Arizona who's been right in my TRT. Meanwhile, we're in Connecticut, who's been right in my TRT. So figure that out. I looked at him and I said, dude, you're on TRT? He had visceral adiposity. He was a chub fest, right? And he said, yeah, I had to start TRT because I smoke pot every night and I get the munchies. Right? Like, whoa, what, like you're robbing Peter to pay Paul here. If you don't have the lifestyle right, no amount of TRT will allow you to be well.
Absolutely. No, I agree with you there. One thing that I am a huge fan of what we're doing at Game Day is that you see the same clinician every time, whether you do it telehealth or you're in person. Because we're at 432, I think, as of this morning, clinics open in 48 states and Canada, you can go 3 miles and you're going to find your local game day. And you're going to find the same care in every game day, whether you're in Canada or you're in Florida. But what I insist on is that you see the same provider, you have continuity of care. My capstone project in residency was actually, the danger of handoff. When you come off of that night shift and you're handing off patients to the morning resident and you're half tired, and that's where the most amount of mistakes happen. When you do I did for years the 7 on 7 off shifts, or the 14 on 14 off shifts, where you're handing off to another hospitalist. That's where the problems happen. Or when you take over a panel of patients and you're taking over, 300 patients even in a longevity practice where you know everything about them, but you're handing off to a brand new clinician that doesn't know anything about them. That's where the mistakes happen. So I take it a little bit to heart when my patients come to me and they're seeing an online provider, and I ask them, well, what's your doctor's name? And they have no idea because it's a different doctor every time. What are your thoughts on that?
Well, we have a very similar opinion about this. And that also probably makes us workaholics, right? So there is something to be said for a team-based approach when everyone on the team is involved in the regular care of that patient, right? Like Florence Comite does this. She does an excellent job with it. For every one Florence, there are 100 Dr. Nicks from The Simpsons, right? Hi, everybody, right? Like that guy, right? And the problem is, put simply, if you are not seeing your people consistently over and over again, there is all sorts of messaging that can be off, number one. Number two, you have to be able to trust your clinician. Trust is earned, it's never given. And number two, suffering with a patient with the aim to help them heal over the long haul is the best healing rapport you can have. And if you don't have that relationship, I know this, I'm a man. If you don't have that relationship as a man, it's transactional. And when it becomes transactional, trust drops and you're negotiating at the bazaar, right? That's the real problem there. So what you guys are doing at game day is awesome. I know you've got one in my town, and they do an excellent job in Stamford, Connecticut. They do an excellent job. I've seen many patients through the years and through the time. And there are some places where I'm not going to smear anyone, where they go, oh, I go see my gynecologist for my testosterone. And you go, whoa, timeout, sit down. What? Well, my wife had this guy and he said he would write me for a little testosterone. I only have to see him twice a year, and he does labs twice a year, and I feel okay. Yeah, no, that's not what's happening at game day.
No, not at all. Let's talk about the thing that actually gets men through the door. Erections. A guy shows up mortified about one symptom. What is that symptom usually telling you about the rest of him?
Oh, so
let's unpack that.
Yeah, right. We literally have to unpack that. About a year and a half ago, I was actually at something called the Silverback Summit. I don't know if you ever heard of it.
Yes, of course.
Right. So Allie is like one of my best friends. Allie Gilbert and I, we started a men's health practice literally in 2012 and 13. Okay. So Allie and I go way back. So I was presenting on erections, right? Hard-ons. And what I said was the following, right? There is something else wrong in you when you can't get your erection, right? It is either cerebral, right? Supply, or neurologic, which is a combination of both. And so you have to go digging. You just don't go, oh, yeah, you're not as hard as usual. well, here's 100 of Viagra. See ya. Bye. Right? Like, let's like use our brains. I told you, right? We are Michelin star chefs. We should not be just saying symptom prescription. There is a real workup. It literally, if you have erectile dysfunction, that's your engine light saying, hi, check me out. Now, in your fancy Mercedes, whatever the heck it is, you got to plug a computer in that to do that now. And so you can't just listen to it and tinker around. We are like that blue tech diesel Mercedes. The human body is so complex that this is not tinker on your own sort of stuff with go out to the gas station and get yohimbine or whatever. You really have to think through the causes of erectile dysfunction because that itself is not the disease. You can't just try and treat that for sure.
Yeah, it's definitely it's the difference between the internet selling a blue pill and calling it a day. That's really what separates sexual health medicine from another vending machine. And an erection is exactly what you said, a check engine light. It's a canary in a coal mine. It's the first place I think a man's heart, his hormones, his stress are all going to show up. And if you ignore it, you're ignoring a lot more than just sexual function.
Yeah, there's no doubt. I've seen it time and time again. It is one of the first things to go. And in a subtle way, I see this more now, I'll tell you, Dr. Hal, with people who have had COVID or who have had post-infectious disease issues. The blood vessels get messed up. The mitochondria get messed up. And I was talking about this on Ali's show. I'm like, you better check those mitochondria because if you are not able to make eNOS or mTNOS, which is the mitochondrial ability to generate nitric oxide, you have a problem. And so those things are essential here. You have to set your body up to be in the right position to be well. And erectile health is literally, just like you said, the check engine light for am I living a life well lived, right?
I'm gonna get back to the mitochondria, but in the meantime, the buzzword of today is peptides, where the podcast bros, the regulators, everybody's at war right now. It feels like you use them clinically. Where is the real published science, and where is the noise?
So this is very important, right? And I'm sure we're going to get a lot of people listening to this podcast, Dr. Hal, not only because you have a good podcast, but I'll tell you this. I was giving a lecture in February in New York City, big lecture, standing room only.
I
And all
remember.
of a sudden, I find out I'm in the New Yorker by some guy who was a hospitalist doctor looking to like bury someone about peptides, never came to me, never talked to me, never said, hey, I want to talk about your talk. No, the guy was a hatchet man. And one of our own. And so, as well as I do, there's a lot of polarization with peptides. That is because there are 3 levels of evidence, and I'll go into this really quick. So I trained in genetics, where we don't have randomized double-blind controlled trials for 100,000 people. We don't have them. Instead, what do we have? A simple question we ask: does the biology make sense? If the biology is established and it makes sense, we apply a risk-benefit ratio to implement things, from medications to supplements to now like Helen Zeto's SS31, right? So I've operated understanding that gray for a long time. Most doctors haven't. They want to have a study that was published in the New England Journal of Medicine of 200,000 people who pin themselves with BPC 157. You're not going to find that ever. So expecting to get that big sort of robust data is not real. There are some peptides that are FDA approved, been FDA approved for years. I think etosamorilin is one of them. Like Tess is called Agrifta. Hopefully you get paid for that. I'd like to throw it out there, right? It's called Agrifta, and It is very effective in encouraging growth hormone secretion. Why are we not playing around with peptides at first that are FDA approved? That's number one. Number two, there are peptides that are not FDA approved that have really robust data. And so I'm going to say it right now. Retta has some of the best data out there. It is very solid data, very solid workup. Okay? I'm not here pushing Retta on anyone. But if you're looking for quality of data, quality of evidence, then there are peptides that are FDA approved that have really crappy data too, Dr. Hal, right? So using FDA approval alone as your guide for peptides probably is not the best solution because everyone's complicated. I turn to a few different places. Abud Bakri was on Huberman the other day, and Abud and I are friends. Well, we're Twitter friends, right? And so turn to the ancient literature, right? Look at what the Croatians did. Look at what Cavinson's early data was. Try and understand that. And if you can't understand that, go to a training course, go to a peptide training course. Like Billy Seeds' stuff is good stuff. There are places that will introduce you to that old literature. That's number one. Number two, understand the FDA-approved peptides and their roles biologically. Don't just say, oh, it's only for HIV patients. No, understand the biology. Because if you're trying to precision tailor care for a patient, biology and basic science must lead your understanding because that lowers risk. That's number two. Number three, I think you and I and everyone else that is helping patients gain access to peptides needs to have a peptide registry, just like we have for when I use stem cells or PRP in people, or when the back surgeon puts an instrument in someone. There are patient registries, and we need to build that. Like I put that on you and on me and Dr. Starbuck and everyone on PCAC. We have to have a real registry here because then when we have that, we can truly optimize care at scale, which is right up your alley.
There's good peptide science that's been around for years, and there's peptide science that's been around since Tuesday. I think teaching patients the difference is our responsibility before they inject something.
Yeah. I'll tell you this. You make a great point. So I take care of a Yale professor, I'm not going to mention his names, who does something in the field of drug discovery. I'll leave it at that because then now I'm starting to narrow down the window, right? That dude has injected himself with more things than I could ever contemplate or imagine. He's a physician and a PhD. So he's got all the knowledge in the world. But even then, if his sourcing was off, he'd have real problems. And this guy has his own mass spec. He's got his own gas chromatograph. He can test purity in his own lab. My buddy Dale at Planet Fitness does not have that. So the first thing that guy needs is a Sherpa. And so we owe it to the patient to get solid with the science as we guide our patients with peptides. That's really important.
Yeah. And I mean, sourcing is absolutely important, right? So 503A pharmacies, patient specific, regulated by the state. And then there's 503B, which is going to be for institutions and clinic use, right? And that's regulated by the federal government. Those are good sources. And then you have the commercial pharmacies. Those are good sources for the brand names. The research use only labels, the manufacturers, that's where it gets a little sketch, right? That's where there's not really much oversight. They might say that there's third party testing and certificates of analysis, but how much can we trust those certificate analyses that I see floating around the internet?
Have you seen on Substack, there's this Crisia, I think is her name. She's literally going to these suppliers and debunking the COAs the certificates of analysis. And what she found is these COAs are all Adobe Photoshopped. Like, I'm serious. I'm not
But they
kidding.
look great, right? They look
Like,
great.
no, but like they're not just airbrush like you've got perfect face, but like in this case, literally the COA, which says X amount of purity of whatever it is, the fonts are changed on the COA. So there are people cutting and pasting Adobe PDFs to sell you, right, like an API mixed with baby powder, right? Like that. This is the difference between compounding pharmacy and research use only. Once you get the API, you have to have a robust process to give that as a deliverable to the patient. If you're not in a clean room, if you're not working with a hood, if the only hood you have is your hood that you're operating your garage peptide place out of, that's a problem. That's a problem. Okay? Full stop.
It's all right. We'll just say it here. If it's labeled research use only, it does not belong in your body. If it's labeled research use only, you are the science experiment. Full stop. We're going to stop there on peptides. It's a very touchy subject, I think, recently. You do a lot of, you mentioned PRP, you mentioned some MSK work, you do a lot of regenerative work. I know for joints and for recovery. For the 45-year-old weekend warrior who's a little beat up, what actually holds up to the evidence and what's hype?
Well, I'll tell you right now, evidence-wise, platelet-rich plasma, when done properly for osteoarthritis, has more data than knee replacement surgery has. I'm going to say that again. PRP has more data and positive studies for osteoarthritis than knee surgery. That's number one. Number two, yeah, you're going to be blown away by them. Most people don't realize that. That data was, a lot of that data came from registries. A lot of that data came from people really doing the work very hard. And a guy like Chris Centeno or my mentor, Luca Podesta, doing work, publishing, keeping their data in a registry. So that's PRP for osteoarthritis. It's a no-brainer. There is some new data on PRP and stem cells in the bone itself, right? Intraosseous injections. Why? Because we know that set of bone that's underneath the cartilage goes bad. It becomes senescent. And so if we can bring regenerative tools into that, that's real. What is hype right now? Muse cells for neurodegeneration. Muse cells for erectile dysfunction. I'll tell you right now, Dr. Hell.
Thank you.
Many a patient have I counseled. Intravenous Muse cells, there's zero evidence for them, right? Let's stop there. They're not going to give you a better erection. I do use PRP in patients that really need it. They need the vasculature. But there's a lot more to it than just going and getting a bunch of injections of PRP. So Muse cells for those sort of indications, pure hype. There are studies for non-Muse cells, right? Which, by the way, let me explain what a Muse cell is. A Muse cell is basically like the cockroach of stem cells. You literally have to create them by nuking all the other stem cells, and the only thing that's left is this resilient Muse cell. It's a multilineage cell. They're very hard to create. So often when people say, I'm using Muse cells, it's bullcrap, right? It's the Chinese peptide kid that you sent a TikTok about a while ago. You like secrets? Come here, I'll show you my secret, right? It's like, oh my God, time out, we're good. And so you can't believe that Muse cells are accurate. There's only a couple places like MCI that make real Muse cells. So that's important. The other thing I think that's very important that is hyped, and I'll tell you right now, there's a lot of hype around Wharton's jelly and what we call umbilical stem cells. The hype around them is
tissue product.
Birth tissue products, correct. There's a lot of hype around them. The evidence for them benefiting the weekend warrior for knee arthritis, for a rotator cuff tear, is non-existent into the air. There's just no data on it. And because of that, you should not be spending $20,000 or $30,000 in Panama for birth tissue products or for Muse cells that haven't been properly sourced. And that's number one. Number two, if you're going to spend 20 or 30,000, you need to do it with a quality team that has been trained forever, not a team who just decided to pop up a shop that's peptides and pluripotent stem cells. Like that sounds fantastic. And in your neck of the woods in Florida, that's happening in beauty salons
Yeah,
now.
yeah.
So when you talk hype, remember there's marketing and then there's medicine. Make sure you get proper medical care with a great medical team before you fall in love with marketing.
That's the best soundbite ever, I think. So hopefully more patients will learn from that. Speaking of marketing and how recently we're getting a little bit of flack for the word of the decade, really the word of the last couple of years for me, right? Longevity. And early on I called longevity primary care for rich kids. And my mind has changed quite a bit since then, and I think it was after having my son, and I've become a longevity enthusiast. I don't call myself a longevity doctor yet because I'm still learning about the field. um, I think half of it's real medicine, what you do. Half of it's a supplement funnel with good lighting. And
That's more than half. Dr. Hal, that's more than half. Let's be honest here. That's about 85% of it is like, I took whatever Brunson's course on how to design a 5-step click funnel, and now look, I've got a backlight and take these. Yeah.
I guess I should stop production on Dr. Hal's vitamins.
No, dude, I'm going to tell you right now. If you really want to spend more time with the family, you make Dr. Hal's vitamins.
I think I want to be able to spend time with my family and look at them in the face.
Yeah. The other part of that is orange and you, probably not a good combo.
No. I would, it would blur too much. It would be, it's not a good look. But give the men listening the version that's actually medicine and longevity medicine, and what's marketing.
Right. Simple. Marketing is an attempt to sell you something other than an opportunity to become resilient, have a life well lived, and to defeat the actuarials of your life insurance policy, right? The guy's actuarials, that's like Gary Brecka, right? And he'll tell you, I went in and calculated when you'll die. Here's the metrics that we use to do it. How do they do that? They have registries and have tracked them for years. Longevity medicine is identifying markers and biology that happens before Gary Brecka's biomarkers. Okay. And it's done through a field called geroscience, which has been around for decades. It has been sneered at by the people studying cancer, sneered at by the people studying heart disease. Why? Because cancer and heart disease kill you. What geroscience says is, yeah, no crap, they kill you. That's why we want to be nowhere near them, right? We want to be way ahead of them because those kill you. And your track record, frankly, sucks cardiology and it sucks oncology. How can we intervene earlier? By identifying factors that, to go back to what I said before, we are made to be well. These factors go awry before we start to get unwell. And so that science is the science of longevity medicine. Everything else is NAD infusions, beautiful babes on a Gulf Stream, and magical guys who stay away from sunlight to look like a vampire and get autoimmune disease.
Boy, poor guy.
Listen, I'm going to tell you right now, he tried his best. He had the wrong guidance because he led not as well with geroscience as with exciting longevity. Real longevity is boring. I'll say it again. Real longevity is boring. It's putting in the effort, right? It's fixing the lifestyle. It is identifying the things that we can change before we start taking 100 supplements. Because if you want to do longevity right, step one, you better find purpose. And as a man, there is nothing more important than having a purpose-driven life.
It's beautifully said. I tell my patients the same thing every day. You got to fix the big stuff, and then I can work on the little stuff. And I'm not going to give you rocket fuel to put in a Honda Civic.
Yep, that's right.
So we need to, I think we need to harp on that more and more. I think that lifestyle changes, is something that we discuss every single day as doctors who are taking care of patients, but maybe they're not hearing it as much. And that's why, we hear outside that, doctors just want you to be sick. And I'm like, what kind of nonsense is that? That's the last thing we want.
Yeah. We
But
want to be with our kids. We don't want to
yeah,
deal with your phone calls,
no,
right? No, seriously, like if I have a great, well-trained patient, they don't need to phone call me because they are living a life well lived. They are being well and they're enjoying their families too. They don't want to bug their doctor. And that for us, I think is a true testament of success, right?
yeah. Speaking of, I know it's almost 8 p.m. and you have your family and I have actually, you have a patient at 8:15.
Yeah, I do. I do. A
And then,
great guy. Great guy.
yeah,
But, yet another guy who's a men's health guy who had been and bounced around to all sorts of places, who didn't get the holistic view, who didn't get the workup and have a continuity of care like you guys have at game day. And so we're going to try and tighten things up with him, but he's in a much better zone now after a year and a half with us, for sure.
awesome. That's awesome. Real quick, broken system, health misinformation. You built drive-through testing before anybody thought about it. You watched misinformation move faster than medicine for years. Where do men actually go for answers right now? Where should they go? My thing is they shouldn't fear the doctor, or they don't fear the doctor. I think they fear that wait, the copay, and the shrug. Everything's fine. I'll see you next year. I think if you take those three things away, and that's what we've done at game day, men show up.
Yeah, I think you're right. I, I'm not going to tell patients to go to ChatGPT as their only source, right? Um, I think men need community more than ever. And so if you can find a community of caring clinicians, caring healthcare providers, and pair that with a community of men who want to help support each other in a good way, you can avoid a lot of that misinformation. And I know um, I've got one biological brother and two like adopted Irish brothers, and they're sending me crap on Instagram and TikTok. Like literally, their mother was one of my first patients, and so they're like, "You got to see my sons." They send me crap, and I'll go to her and I'll be like, "Dude, not at 1 a.m. I need my sleep." And so I then say, "You need your sleep too." That is community. And so if you can get that at game day, you are light years ahead of anyone else trying to help patients through this morass that we know as healthcare.
I got one last one for you, and it's not a clinical one. You're a teacher, you're a professor. You treat, you build, you write all day long. What does the man behind all of that want his kids to know? His kids to remember how he practiced medicine.
Hmm. Yeah. Dude, that's not cool. You make me cry. It's a men's podcast here. I'm going to start tearing up. I want to tell you something for all your listeners too, right? So I record little snippets for my kids on my road, on my podcast board, right? I've got an SD card in there with a headset. In my quiet moments, I'll drop a 1 to 3 minute little dad's rant It's not really rant. It's just like, holy crap, this was really challenging today. I want you guys to know that here's these things that have happened. If we do not shape our legacy for our children, someone else will. So this question matters to me more than anything else. And you really hit it. I want my patients to feel loved. I want my children to know that I loved my patients, because it really is caring for the patient that gives you the best patient care. And so when my kids had to be quiet because I was on with the patient, I want them to know it wasn't because I didn't like them screaming, the wheels on the bus or whatever. It's because I cared for that patient. And in the moment I was with that patient, I gave them all of me, all of my attention, all of my energy, all of my love to get them through a rough patch. And so that's the one thing I would love my kids to understand. So thank you for asking me that. That's fantastic.
That's the show. Get the right information, find the doctor who treats you like a person, not an average, and do it before the wheels fall off. Gentlemen, like he said, we are made to be well, so go be well.